Yes, we are able to record today. We are currently recording.
Thank you so much. Good morning. Today is May 20th, 2020, and this is our 8th in a series of biweekly calls for Medicaid behavioral health providers. These calls seek to provide verbal updates on our response to the COVID-19 state of emergency and our associated guidance. My name is Dr. Alyssa Ward. I am the Behavioral Health Clinical Director at the Virginia Department of Medical Assistance Services. We appreciate you all being here with us today for this WebEx event, and due to our usually large number of participants, everyone will be muted today except for our panelists. If you've been on past calls, you've seen that last week we stopped answering questions live in the Q&A function as we want to assure that we promote focus on the call and assure you that we will respond and assure that we are responding with the most accurate and up-to-date information possible. So we're going to continue that again this week. We're going to ask that you hold your questions and send those to us through our two email accounts, enhancedbh@dmas.virginia.gov. For mental health questions, and sud@dmas.virginia.gov for arts-related questions. Please reserve the chat function for technical or logistical questions. And if we have time at the end, we may be able to attend to some questions, which we will pick from through the Q&A function if time allows. But we want to advise that we may not be able to answer all of those questions immediately and want to assure, again, that we are most accurate in our responses. It is, as always, possible to listen into this event over the phone. We do encourage participation on your computer as we do have some slide content to share. It is being recorded and we will work to integrate it with the rest of our posts on our website. I am very happy today to be joined again by Dr. Cleo Booker, our Senior Program Advisor in Behavioral Health, Laura Reed, our Manager for Behavioral Health Services, Ashley Harrell, our Senior Program Advisor for Arts, and Anna Shawley, our Support Act Grant Manager. We can move to this agenda to show you what we have to discuss today. This is going to follow our typical flow for the call, where we provide some global updates on what is happening in behavioral health and Medicaid under the state of emergency. We have some resources to share with you today, and just a few frequently asked questions that really capture the tone of the moment right now. What I do want to start with today is, as always, thanking you for your collaboration and feedback. We have continued to receive a lot of different questions and concerns from providers, and I've noticed that these have changed and shifted thematically as we have all moved and adapted together through this process. We are 10 weeks into this experience, and certainly in many ways in uncharted territories. But we are charting those maps together right now. As we have entered into phase 1 of the governor's plan to reopen Virginia, we know that your questions have changed. The types of questions that folks have are different. And these vary across localities across the state as the phases are being implemented on variable timelines. We are very aware that with this opening comes a mix of experiences for providers and members, including, on one hand, encouragement that we're moving closer to our shared goals in defeating the coronavirus, and at the same time, anxiety about what these openings mean for services, for business models, for safety, for member access to care, and for all of our engagement together. We are right in those experiences and feelings with you. We have continued these calls because we acknowledge that the coronavirus and our collective systems response is a moving target. And we are doing what we can to communicate as much as we can about our policies as they evolve to reflect both our federal and state allowances. Further, we seek to provide you with as much guidance as we can based on empirical sources and recommendations that come from a variety of trusted sources. So we would like to start by referencing the two DMAS memos that we have released providing guidance on these flexibilities. They're available on the DMAS website. I believe we have a picture of that. There they are. As well as a communication that we sent out last week to providers. We sent that out through a couple of different blasts and through our stakeholder work group email. This communication that went out was a response to the number of questions that we received about the implementation of phase 1. So we have some information about that on the slide now, and I'm going to say a few more things, and then I'm going to come to the content of this slide. And for those of you on the phone, I'll be sure to cover all the content on the slide. But we just want to make note of a few things. Our frequently asked questions have been posted on our website. The memos are available through the DMAS website. Any information that we have about changes to these flexibilities or prohibitions or allowances will be formally communicated before they are expected to happen. 2 weeks ago, we moved, actually, well, I should say a month ago, we moved to bi-weekly calls, every other week provider calls. If we have a sense that things are changing rapidly or we need to provide more updated information, you will be notified by email of an additional call in the intervening week. And so the calls we anticipate will remain at this predictable time, but if we do need to move back to a weekly cadence or just bump it up to have 2 calls in a row due to changes happening with the coronavirus and the system response, we will do that. We also have had some questions about the status of the 1135 waiver. I just want to note that, as we said last time, it has been submitted. We've been in conversations with CMS. We are still awaiting approval from CMS, and that the Appendix K was approved. So going back to the slide that we have up right now around these flexibilities, we want to underscore that, as is stated in our memo, these flexibilities remain in place during the state of emergency in Virginia or until otherwise formally notified. So all of these different flexibilities, allowances, directives, limitations around the delivery of behavioral health and art services, they are stated in that March 27th memo, and they are going to extend through the state of emergency. It is possible, as I hope that you all realize, these different states of emergency as declared by the federal government or the state government, they could change because the coronavirus impact changes week to week, and that also changes based on reopening, as we've seen in other states. So that what happens and the state's response to it and executive orders that come out of that are, as I said before, a moving target. We expect that DMAS providers, our managed care organizations, and the Behavioral Health Services Administrator of Magellan of Virginia shall continue to operate under that published guidance and those memos and directives until notified otherwise. We are working with multiple state agencies and provider associations in thinking about best practices on the implementation of reopening and how we can provide some guidance and continue updating that guidance based on science and what we know is best in terms of making decisions about how to engage in face-to-face contact, keeping the safety of our members and those who are providing services our priority. So I know that people wonder and are concerned that things are changing rapidly and that they want to make sure that they are aware. Just know that if there are any significant formal changes to the service delivery allowances right now, that those will be issued through a formal memo, subsequent email blast, and a provider notification. At this time, I'm going to hand the reins over to Ashley Harrell.
Thank you, Dr. Ward. Good morning, everyone. I also want to thank you for your continued collaboration and endurance during the state of emergency and continuing to support one of our most vulnerable populations. As Dr. Ward mentioned, we have all of this information is posted on our website. As we showed you earlier, the directives, the recordings of these sessions, the webinars and frequently asked questions remain effective until the state of emergency ends or otherwise notified through DMAS. So here are the links. I encourage you to sign up to start receiving automatic notifications of any guidance posted by DMAS. And I'm going to put this link is to our provider section of the COVID-19 updates. Next slide. So on April 7th, yes.
This is where we lost you for a second. Would you mind reviewing this slide again?
Yes. Sorry about that. So I encourage all providers to sign up to start receiving the automatic notifications of guidance as posted. And the first link that I posted in the chat function is where you could go to sign up for these notifications. And then the second link is where we have posted the behavioral health and arts COVID-19 guidances, directives, recordings, webinars, and the frequently asked questions that we showed you in the earlier slide. And as Dr. Ward mentioned, these remain effective until the state of emergency ends or otherwise notified by DMAS. Next slide. So on April 17th, Governor Northam issued Executive Order 57 to address the increased demands on the Commonwealth's health professional workforce. This order was amended on April 23rd, 2020. This action authorizes out-of-state licensed professionals to practice in the Commonwealth and will assist in meeting the demand on the workforce. So effective April 17th, a clinical psychologist, professional counselor, marriage and family therapist, and clinical social worker with an active license issued by another state may be issued a temporary license by endorsement as a healthcare practitioner of the same type for which such license is issued in another state upon submission of an application and information requested by the applicable licensing board and the board's verification that the applicant's license issued by another state is active and in good standing, and there are no current reports in the United States Department of Health and Human Services National Practitioner Databank. Such temporary license shall expire 90 days after the state of the emergency ends. During such time, the practitioner may seek full Virginia license or transition patients to a Virginia licensed practitioner. Healthcare practitioners with an active license issued by another state may provide continuity of care to their current patients who are Virginia residents through telehealth services. However, if they want to acquire new patients, they must apply for full licensure in Virginia or an accelerated temporary license. Providers may get more information at their appropriate board website if you visit www.dhp.virginiaspelledout.gov. This allowance of licensed mental health practitioners who are licensed out of state resulted in Virginia having as many licensed mental health practitioners registered in 1 month as we typically do in a year. This is huge news for historical problems with the licensed mental health workforce. As you see here in this slide, these are the types of clinicians that have received a temporary license. Significantly, 188 clinical psychologists, 131 licensed professional counselors, 113 licensed clinical social workers, totaling 460 since the state of emergency, this authorization was implemented. The significance, next slide, the significance of the out-of-state licensed provider allowances, as well as the flexibilities of the delivery of behavioral health services via telehealth, have allowed members to continue to be safely served during the pandemic. Thus, we want to provide you with an update to the telehealth billing requirements. As noted in the March 19th memo for general telehealth guidance, behavioral health providers should move to systems changes to allow place of service codes 02 and or the GT modifier to reflect telehealth delivery, as this will be required at a future date. Providers shall refer to the previously issued DMAS guidance in the May 2014 memorandum titled Updates to Telemedicine Coverage for billing guidance and a list of codes that are currently allowed to be billed with the GT modifier. DMAS will notify providers in advance through a separate memo when they will be required to use the appropriate modifier or place of service code for delivering behavioral health services via telehealth. We do not have a firm end date for these flexibilities, as they are provided through a combination of federal and state allowances. Creating a path forward for telehealth is a DMAS priority at this time, and we will continue to update you as we make developments in this area. And now we will transition to behavioral health resources for you, and I will pass this to Anna Shalley, our Support Act Grant Manager.
Great, thank you, Ashley. The purpose of the Support Act grant is to increase the substance use disorder treatment capacity of providers participating under the state Medicaid program. The grant team recognizes the new barriers substance use treatment providers are experiencing during the COVID-19 state of emergency. In response, we're offering technical assistance and training webinars focused on substance use disorder related topics and treatment practices with a focus on telehealth. These technical assistance and training webinars are designed to increase substance use disorder knowledge and to provide support to anyone who serves Medicaid members with substance use disorders. These webinars are provided by our behavioral health addiction specialist, Paul Brosler, and our addiction medicine specialist, Dr. Mishka Turplin. We have several topics offered throughout the week, and then a weekly question and answer session at 11 a.m. on Fridays with both Paul Brosler and Dr. Turplin, where we invite you to bring any questions you may have about clinical practice for our experts. We greatly appreciate providers' participation, conversation, and willingness to share their challenges and successes during these sessions. Next slide, please. Here are the first few trainings that we'll be offering in June as well. We have our schedule posted on the dmas.virginia.gov/pound/arts page for additional dates. Next slide, please. Each webinar is provided via WebEx and can be accessed through these links. You may also go to the DMAS website, dmas.virginia.gov, navigate to the arts page by clicking arts under programs and services on the left, and then scroll down to the Support Act grant section. We'll be regularly updating our dates in this location. We greatly appreciate all of the support, participation, and feedback we have received about these training opportunities. Feedback helps us understand what future topics should be addressed and what previous offerings should be offered again. Whether you have attended our trainings in the past or not, we invite you to take our survey to let us know which topics we should offer, which should be repeated, and what time of day these sessions would be most convenient. Next slide, please. And a quick update on other Support Act grant activities. Due to the nature of COVID-19 and providers' adoption of telehealth services, we've decided to reallocate funding originally allocated for the development of a telemedicine curriculum. We are currently in the process of developing a project that will directly support substance use disorder treatment providers, considering the recent transition many have made to telehealth services. A significant focus of the grant currently has been the aforementioned technical assistance series. Last week, we trained over 341 attendees. Our cumulative attendance numbers are reaching 2,000 since we began our web-based technical assistance at the beginning of the state of emergency. We're also finalizing the result of our office-based opioid treatment program and OTP service survey results. We have been glad to see that the majority are accepting new patients, and our statewide estimated capacity for new patients is around 1,000 for OTPs and 3,000 in OBOTs. Additionally, several OBOTs are willing to initiate new members on buprenorphine with the goal of transitioning them to community-based providers at a later date. And they're willing to initiate these members via telehealth to transition them at a later base to community-based providers. Next slide. We also want to provide resources for naloxone. Medicaid will reimburse for naloxone or brand name Narcan. There's also currently a standing order in Virginia which allows Virginians to go into a pharmacy and request naloxone without a prescription. There are several online opportunities to be trained in the administration of naloxone, including from GBHDS's Revive program, who's offering online trainings, and from the website getnaloxonenow.org. We also want to inform you of a program by the Virginia-based nonprofit, the Chris Atwood Foundation, which is providing free naloxone to any Virginian, regardless of insurance, via U.S. mail upon completion of this online form. Next slide. There are some Project ECHO opportunities for our provider community. VDH Project ECHO is offering COVID-19 infection control and best practices in clinical settings. This is occurring tomorrow, May 21st, from 12 to 1 p.m. Next slide. VDH Project ECHO is also beginning to offer buprenorphine waiver training starting next Wednesday, May 27th at 9 a.m. At this time, I will now turn it over to Dr. Booker for FAQs.
Good morning, everyone. Thank you all for joining us once again to go over our updates. Thank you for your dedication and your support to a vulnerable population during these trying times. I know that the past few weeks have been very difficult, very fast-paced moving and trying, and I really appreciate you all's support and your courage to continue to do the work that you're doing each and every day. In lieu of, we are going towards the end of Mental Health Awareness Month. I hope that if you have not had a chance to pause and take care of your own mental health, that you do so. You just pause and take a moment to reflect on how strong you are at getting to this point already during this pandemic, as well as just, reflect on the moment and appreciate who you are. Just for a moment, just pause. So I hope you're able to do that if you haven't been able to do that before the end of the month to celebrate what we all support, which is mental health. Next slide. We only have a few general FAQs this morning for me to go over. Much of have already been discussed. The first question is what's kind of on everyone's mind in regards to the governor's state of emergency is due to expire on June 10th. How much notice will providers receive from DMAS when telehealth allowances change? As indicated earlier, the current flexibilities afforded in the DMAS memos and policies are approved through a combination of state and federal allowances, and thus timelines for availability are subject to change from numerous sources. When we do change any of the flexibilities or the telehealth allowances, a memo will be published to provide guidance on each flexibility as information is available regarding expiration, continuation, or permanent integration into policy. Question 2 out of 4. I am confused about telehealth place of service O2 and modifier GT. Should I use them now? Do I need to use them both? Even though they are not required, what if I did not get the service authorization with the modifier approved? As previously noted during this session and as noted within previous memos, we are encouraging providers to get their systems prepared for a place of service O2 and/or GT modifier. At the present time, it would be best for you to review the DMAS guidance from May 2014, updates to telemedicine coverage, where they list the codes that are currently allowed to be billed with a GT modifier. DMAS will notify providers in advance through a separate memo when they will be required to use the appropriate modifier or place of service for delivering behavioral health services via telehealth. What flexibilities will remain in place after the state of emergency? At this time, we have not made a firm determination on what flexibilities may remain in place, but we are definitely exploring various options and we welcome feedback if you would like to share that through our email boxes. And last of the general questions, question 4 out of 4, what are we supposed to document to support services delivered via telehealth? Services delivered via telehealth, either audio and or audio visual, must have accompanying documentation in the member's record that states the alternative location used and that the service was delivered via telehealth to support access to care during the state of emergency. Evidence documenting appropriate patient-informed consent for the use of telehealth services must be obtained and maintained. Appropriate informed consent should, as a baseline, include at least the following, which is identification of the patient and the professional, the types of activities that you are using via telehealth that's permitted, an agreement by the patient that this is the role of the provider that determines whether or not the condition is appropriate to be treated via a telehealth encounter, details on security measures that are being taken to make sure that the information is secure and that these files will be encrypted, and a hold harmless cause for information that may be lost due to technical difficulties or failures. At this time, I'm going to turn it over to Ashley Harrell to go over some ARTS FAQs.
Thank you, Dr. Booker. So question 1 out of 2. What are the requirements for care coordination for preferred office-based opioid treatments or OBOTs, as well as opioid treatment programs during the state of emergency? And this is related to the care coordination billing code of G9012. The answer is that OTPs and preferred OBOT providers are able to be reimbursed for substance use care coordination activities during the state of emergency and must meet the requirements in the ARTS program manual. Substance use care coordination includes activities to ensure that necessary medical, behavioral health, or social services are available to the member, monitoring member progress, and tracking member outcomes and reporting updates to the treatment team. DMAS has issued flexibilities for care coordination to be provided via telehealth or telephone during the state of emergency. I wanted to emphasize to you the minimum requirements include participate in the interdisciplinary treatment team meetings for care planning at least once every 30 days for each member, monitor the provision of services, including outcomes, assessing appropriate changes or additions to services, as well as facilitating referrals for the member, ensuring that the individual service plan as well as the individual plan of care are developed and updated as necessary, ensuring that appropriate mechanisms are in place to receive member input, complaints and grievances, and secure communication among relevant parties, solicit and help support the member's wishes. This may be around healthcare decisions, prioritization of needs, and implementation of strategies. And lastly, providing education as needed to support informed decisions. So this language, again, this is exactly what was in the ARTS program manual, and these are the minimum requirements to be able to bill for that care coordination within the preferred OBOT and OTP. Next slide. So the second question, can opiate treatment programs be reimbursed for the prescribing and dispensing of medications for take-home dosages during the state of emergency? And this is for procedure code H0020. DMAS is allowing the flexibility of the rule defined in the ARTS program manual, which limits the reimbursement of medication administration encounters within opiate treatment programs to only those encounters when the member is presenting in person daily to get their medication dose. However, during the state of emergency, the opiate treatment programs received approval from our state opioid response authority to administer medication as take-home dosages, which can be up to a 28-day supply, to minimize the exposure of COVID-19 to staff and patients. Thus, DMAS is allowing for the reimbursement of the medication encounter for the total number of days supplied of the take-home medication. This flexibility is critical to minimize the face-to-face contact during the emergency and is effective for the duration of the state of the emergency. This information is actually detailed in a DMAS memorandum that was recently posted on May 15th, titled Additional Provider Flexibilities Related to COVID-19. And now I will pass it back to Dr. Ward, for final words.
It is 11:40, and so we have a small amount of time here, and I am looking to see there are the links that we have provided in the chat, and I see that the Q&A function does appear to be available. We have a few moments. If folks would like to enter in questions there, we can review them. There might be some pauses here while we review, but we could review and see if there's any that we would be able to answer if you all would like. So I'll pause right there and see if any show.
Excuse me, Dr. Ward, this is
Yes.
Laura. There's been a couple questions that were sent to me directly.
Okay.
Several of those I've asked that they send those to the enhanced BH because I don't believe we'd be able to answer them on this call. But there is one from Christy Izanko that she posed during the time that Ashley was reviewing Executive Order 57. And she asked that we address that LBAs and LABAs are not included in this because they are licensed by the Board of Medicine. Other than that, I think all the other questions I've sent to the enhanced BH box.
Thank you, Laura. Dr. Booker, do you want to comment at all on Christy's question? Christy, we can also speak to that on our call we have coming up with you.
Dr. Ward, this is Ashley. I posted the link to the Emergency Order 57 in the chat box.
Oh, thank you.
You're welcome.
And the question was around the data not including ABAs. Is that correct?
Laura, can you confirm?
Good.
So Christy said, do you want to address that LBAs and LABAs are not included in this executive order because they are licensed by the Board of Medicine, which has similar but not exactly alike flexibility?
I mean, we can just mention, Christy, that this executive order and the work that went behind it is from our partners at DHP, and it was an allowance made for the licenses under those boards mentioned. And questions, regarding moving towards similar allowances for LBAs could be directed to DHP.
We're also getting a lot of questions about where people can get information concerning our PowerPoint slides and the recordings of our bi-weekly webinars. So currently I have the screenshot of our emergency waivers website up, and this is where individuals can seek information on our webinars. It has recordings of most of our webinars, as well as the last 2 slide decks for the last 2 webinars, and we will upload today's webinar and that slide deck as soon as we can.
I do see a couple of questions here that I think we can answer. One from Leslie Bottoms that says, will DMAS provide guidance and safety precautions for reopening of congregate settings, specifically PSR? We are working to develop interagency guidance, as I mentioned earlier in the call, because there are many different agencies that touch congregate settings, and we want to assure that we have consistent guidance that goes out, for example, from the licensing bodies at other agencies and us as a funder. And so we are currently working and engaged in that process, and we do seek to provide that guidance and safety precautions going into opening. I see that Mindy Carlin has a question about TDT dates.
Yes.
Yep. Is that Dr. Booker?
I can take that.
Sure.
So there have been questions about TDT summer and when will TDT in school versus summer TDT begin, and is this specific to each school division? In regards to DMAS, when the TDT authorization ends is when a new authorization should be requested, unless you are having to end the service auth yourself because you're changing the modifier or you're changing the place of service, like where it's going to be delivered. But I want to be clear that even providers right now that are providing TDT, if you have a license for a TDT in school, and you do not have a license for TDT out of school, we have prohibited from the beginning that you're allowed to do TDT out of the school if you're only licensed for TDT in school. So you could continue doing TDT if medically necessary and appropriate, even if you are only licensed for TDT in school at this time.
I'm looking through. Anna, Shali, there is a question from Sherry Hartman asking if there is a charge for the waiver training. Are we able to answer that?
Hey, Dr. Ward, this is Ashley. I can answer that one.
Sure.
So the trainings for the buprenorphine waiver are actually being funded through the Virginia Department of Health. So there is no charge for these sessions. There is the one session that is being offered this month, and then there are 3 additional sessions. And so I encourage you to visit that link. I also put that in the chat box to get the additional dates, which are actually, I will pull it up now so that you're aware. So the first buprenorphine waiver training is May 27th from 9 to 1. The second is June 24th from 9 to 1. And then July 29th from 9 to 1. And then the final one that BDH is offering is August 26th from 9 to 1.
Thank you, Ashley. I apologize. I was double muted.
You're welcome, Anna.
I noticed that there are a few questions about flexibilities, and I have to be honest, some of the ways that the questions are phrased, I'm not sure that we're able to respond to them. So if you did submit a private question to the host regarding, for example, units of face-to-face visits or billing of face-to-face versus telehealth, please review the memo. And then if you still have a question, because nothing has changed from that memo, you can send it to the enhanced BH mailbox, and we can respond with reference to the where that piece is covered in the memo and clarify any questions you have.
I'm also seeing a lot of questions related to TDT. And also it appears that some of those questions may be more in depth or case specific. And so if you could send those to the enhanced BH email address as well, we will be able to provide more technical assistance than available on this call.
I also see a question that was sent privately from Daryl Washington saying, given the high incidence of COVID-19 in Northern Virginia, it is not conceivable that services would be safe to reopen on June 10th. Is there an estimate on when we will hear about a time extension on the emergency regs? And this would be helpful in reopening planning. We agree, and we also are awaiting any timelines and extensions. As I noted at the beginning of the call, these things are moving targets and have both federal and state variables attached to them, as well as the status of the virus and how it emerges and evolves in different areas of the state. So we don't have any information today, but we are that is our top priority, is assuring that we have that information as soon as it is released so that we can share it in a most efficient way with you all, so you can prepare for when reopening may be granted in terms of these types of services. And again, I want to emphasize there's multiple variables here. So there are social distancing guidelines, there are flexibilities and allowances. There are the governor's prohibitions and allowances that come kind of with general rule and business operation within each of the phases. And we really see it as our job to sort through all of those for you and to deliver the information to you as rapidly as possible as they reflect your business as a behavioral health Medicaid provider, and the services specifically that you provide to our members. So we are staying abreast of everything, or trying, I should say, we're all trying to stay abreast of all of those different moving targets. And then that's why we continue to do these calls in addition to the formal memos, so that we are able to give you any information when we have it. We just don't have anything today.
Dr. Ward, this is Laura. We're continuing to get requests for the PowerPoint and if those are going to be sent out and where those could be found. And I just wanted to repeat that the PowerPoints and the recordings of our webinars can be found on our emergency waiver website, which is up on your screen. The website is up at the top of the slide. And please know that we will get the PowerPoint posted as soon as we can within the next few days. And if you are on our listserv, generally speaking, you will receive an email with that PowerPoint, as well as they are generally posted to the Magellan, Virginia website as well.
Thank you, Laura. Well, in the absence of other questions that we can respond to at this time, I am going to end the call. We appreciate so much participation. We hope that, you know, the numbers that continue to show up for these calls are an indication that you do find the calls helpful and supportive during this difficult time where we know you're navigating those same moving targets that we are. And we will send out an invitation for 2 weeks from today. If anything changes that we want to make you aware of and think you need to know in the intervening time, we will either send out a communication through blast like we did that is not a formal memo, or we will schedule another call in the intervening time period. But otherwise, please stay safe and contact us via our email at enhancedbh@dmas.virginia.gov and sud@dmas.virginia.gov. And we look forward to connecting with you again very soon. Thank you for all you're doing to serve our members during this difficult time.